So welcome everybody. Good evening, good morning, good afternoon, depending on where you are. And welcome to this webinar from the IFCC and the Committee on Clinical Application of Cardiac Biomarkers. We have a program today focusing on interference on high sensitivity troponin assays. And before we start, I would just like to show you a few slides, a little bit commercial about our committee. So, first of all, if you want to, I would really recommend everybody to go into the IFCC webpage and look at our committee. You will find us under the Educational and Management group. And especially, I would like to highlight the biomarker reference tables. If you click on those, you will come directly in and have information, all the core and important information about high sensitivity cardiac troponin assays and natriuretic peptide assays. So all the relevant information, analytical information, is here, and also there is information about interference, not antibody-mediated interference that we will focus on today, but more the regular interference that we see in daily use. Further on, I would recommend that you look at the published manuscripts if you have any questions. Those are educational documents which provide guidance on how to use cardiac biomarkers. And for those of you interested in antibody-mediated interference that we will discuss today, I will particularly highlight this manuscript that was published very recently, which discuss this topic more in detail. Also, finally, if you are interested in our webinars and you want to see this webinar once again later on, or any of the other webinars we have, you can just go to the web page, click on the webinars, and click on the title of the webinar, and it will take you directly into YouTube, and you can watch everything again. So that's the little commercial, and then we start on today's program. And it's a very, I'm very happy to introduce the first speaker, which is Dr. Pete Kavsak from the Department of Pathology and Molecular Medicine at McMaster University in Hamilton, Canada. Dr. Kavsak is a professor and has published extensively on cardiac biomarkers, and particularly troponins, including both clinical use of the assays, but maybe even more analytical performance and analytical issues related to cardiac troponins. So we are very happy that you are here, Pete, and I welcome you and to present your topic, which is analytical and biological interference for cardiac troponin assays. What should we look out for and when?
Well, thank you very much, Kristin, for that kind introduction. And thank you everyone for attending today's webinar. So today I'm going to be talking about analytical and biological interferences for cardiac troponin assays. And, you know, what should we look out for? Well, really errors. And when do we do that? Well, we need to be doing that in the laboratory so we provide some reliability to the test that we perform. And so I think it's really important that laboratory professionals and others actually appreciate that there are many variables that can affect cardiac troponin assays. Oops. So I do have some disclosures. The majority of my funding has come from the Canadian Institutes of Health Research. However, I am grateful for industry that has provided some support over the number of years. And for those who want to know what generative AI says about my disclosures, there's a nice little text that's on the right-hand side on here, which I was able to get from generative AI. Unfortunately, can never repeat this type of nice, kind text. So maybe a warning to those who use generative AI that if you like something one time, you may not see the same thing again. But I do think that it's important to disclose, obviously, financial among other aspects related to presentations. So what are the objectives for today's presentation? Well, there are really just two. One is to describe the different analytical and biological variables that may affect cardiac troponin assays. And the second is to recognize the impact of interferences on patient risk classification and identification of myocardial injury. And why we need to do that is in this particular setting, the lab is an interface between patient care and the clinician who's evaluating the patients. So it's really important that laboratories actually understand what could possibly lead to discrepant cardiac troponin results, specifically in the hospital and even in the outside hospital setting. So what should we look for? Well, here are 5 bullet points of variables that can affect cardiac troponin assays. And over the next few minutes, what I'll do is I'll go through the different examples of how these types of variables can impact cardiac troponin results. So first bullet point, clustered 4 things that are very important, but they're kind of pre-analytical. They start off with obviously the sample type, to transport of the sample to the lab, centrifugation, and how that sample is stored prior to testing. The second bullet is something that we're all very familiar with any clinical chemistry test, and these are the types of interferences such as hemolysis, icterus, lipemia, turbidity. The third one is perhaps something more specific for immunoassays, where we have antibody interferences. The fourth one are macro complexes, and you'll hear a lot more about them later in today's webinar. And finally, there are exogenous interference that we have to be mindful on, as well as endogenous interferences. And again, why do we need to know this? Well, we need to understand all these variables so we can actually provide accurate results. So where do we start? Well, sample type. In the first publication back in 2009, looking at the clinical and analytic utility of a high sensitivity troponin assay, and this is on the left hand of the side, it was really evident in looking at healthy volunteers that there's a difference between serum results and heparin results. Now, again, because this was one of the first publications, the population sample size is woefully inadequate as today's standards, but it is important to note that you do see these differences between serum and heparin results. And that's really important. And the fact is that changing sample types may give you slightly different results, which in the context of physicians interpreting rising or falling patterns may lead to misclassifications. So sample type's important, and we'll touch on that later on the talk. The second is transportation. And here's a nice study out of Canada where they looked at transporting samples from one site where the collection to another site, and they did not control if the samples were kept stable or if they were agitated or not. And so as you can see here that there were definitely some samples that actually yielded higher results, and actually a proper recentrifugation of that sample yielded lower results. So it's important to note that sample transport may have an impact. And again, the laboratory wants to put in mechanisms in place to prevent that. The third thing is centrifugation. And here's a study that we did many years ago, where we looked at a quality control material for high sensitivity assay in a regular or contemporary troponin assay. And you can see here that if we had this material and we mixed it only, we tested high sensitivity, we had actually 10-fold higher results than the contemporary assay, which doesn't really make sense. However, if we actually were to centrifugate it, it brings it down to similar results as a contemporary assay. So it kind of highlights the importance that we have to be mindful, and we have high sensitivity assays that we really want to put in place proper centrifugation. And the last aspect is storage. And it's really important that laboratory professionals look at the IFU or the package inserts and look to see what the stability claims are. And as you can see on the right-hand side, that they're, depending on what sample type you use, you could actually have different stability of troponin in the specific sample type. So in this particular assay, it looked like lithium heparin was more, troponin lithium heparin was more susceptible to degradation as compared to serum and EDTA. And this is evident not just for one type of troponin assay. You can see in the slide and the table below, there's other types of troponin assays that we see that same type of degradation. And importantly, it's important that we look at this at room temperature, as well as 2 to 8, where perhaps samples are stored after testing, and maybe even after freeze thaw, which can occur mainly into possibly research settings. And this is just to obviously illustrate the fact is that one has to be mindful, especially when you do freeze thaw or take samples from the storage, that you do have to centrifuge samples, because some assays will have widely falsely elevated results. So again, attention to sample type, preparation, and storage, very important. Well, what about hemolysis, icterus, and lipemia? Well, hemolysis has been known for quite a while to affect cardiac troponin assays. And here's a nice study that was published 13 years ago that looks at the impact of hemolysis, where for one particular troponin assay, there's a decrease. And as you can see, is that the greater amount of hemolysis, the further the drop in troponin T here. And the inverse is that another troponin assay, the increasing hemolysis led to an increase in troponin results. So again, important that individuals understand how hemolysis may affect their particular troponin assay. Icterus is something that has kind of gone underneath the radar. There's not been a lot of studies that have assessed icterus. Some studies suggest there may be a minor effect, perhaps only at really elevated levels, but it's something that individuals should be mindful on. And the last thing is lipemia or turbidity, and this has to do to perhaps non-specific binding or some other type of interference. And here's just a plain example where when you compare 2 different assays and you see these types of outliers, and here we have 3 different outliers, very different from where the differences between the troponin assays typically stand, about 1 nanogram per liter difference, and you see these 3 stay apart. So in the course of that type of investigation, one would want to look at that sample and investigate, is there a particulate matter, and perhaps recentrifugation would be important for that. What about antibodies? Well, there are 2 actually types of antibodies. There's a lot more, but I'm just going to focus on 2 types right here. One is an autoantibody, and you can see here that it's been known for quite a while that the presence of autoantibodies may lead to under recovery of troponin testing. So you may get lower values. And here's a nice publication in Clinical Chemistry 5 years ago that actually illustrates that some of these autoantibodies are to the ternary complex of ITC. So it not only affects troponin I, it may also affect troponin T concentrations. And the fact is that in the early course of perhaps evolving myocardial injury, you may get falsely low or lower concentrations as the ternary complex is released in patients that have these autoantibodies. And then we have the heterophile antibodies. And, you know, commonly we think of heterophile antibodies as human anti-mouse antibodies. There could be other types of antibodies. But here I just want to provide you a nice case report where we actually had a heterophile antibody affecting the contemporary assay. So you can see here all the different measurements around 0.30. So that's equivalent to about 300 nanograms per liter. But because it's a contemporary assay, you know, we report in micrograms per liter. And you can see with the high sensitivity assay, the actual results of the same manufacturer are undetectable. And so sometimes to transition from a contemporary assay to high sensitivity assay, there's been improvements, and in doing so, some of these previous quote unquote HAMAs have been mitigated by the use of different designs of the monoclonal antibodies. And in this case, they use a chimeric monoclonal. So this leads to macro complexes. And there are 3 different points, and there'll be more about this later. But one thing that laboratory professionals may appreciate early off the top is that when investigating a macro complex, if you measure it with another assay, typically, not always, but you'll see vastly different results between troponin from different assays. Yes, there's no standardization between troponin and I assays, that is for sure. However, there is usually some sort of agreement. But when you see vastly different results, for example, this particular result where one troponin assay is, yielding close to 1500, yet the other troponin assay is yielding around the 12, you can see that that's a vastly discordant or discrepant result. And you can see in the table below, this particular sample came from a patient where possibly the macro was affecting 2 of the 3 high sensitivity troponin assays, whereas another macro up here affected all 3. So it's something that should be obviously laboratory professionals should be aware of, that macros can exist, and you'll start to think that it may be possible when you see vastly different results. The second aspect is that sometimes early in the course of investigation of a macro, you might see that there's differences between sample types as well. So quite often you'll obtain a lithium heparin, perhaps a serum accompanying that sample, or perhaps EDTA. And typically there's a relationship. You don't want to use them interchangeably, but you feel that there's definitely an relationship between EDTA versus lithium heparin. And for some assays, EDTA runs lower. But where you see there's absolutely poor agreement between sample types, that may also indicate or perhaps suggest there's some type of interference here. And so you can see here in the table below, if you look at this sample from number 741, we can see that lithium heparin is 6.7 and the EDTA is almost an 18. So very different results from the same draw in the same individual, suggesting that there's probably something in there. In this case, there was. And then the last thing is that it's probably very important that there are different approaches to identify macros. Both PEG and protein A are suitable for certain assays. And here's a nice publication by Drs. Lamb and Kyle that look at this. You can see on the y-axis, you have PEG recovery. On your x-axis, you have protein A recovery. And you can see there is a relationship there. More so, they've also went a little bit further in using support vector approach, and they also have identified that typically macros yield very different concentrations when you compare one assay versus another assay. And here you can see that the macros here in the pyramids, or sorry, in the triangles, you can see that they are running very differently in the fact the axis, the assay on the y-axis background is about a third of the values, or at least, or lower than what's on the x-axis of semen. So again, sample types, measuring between different assays may identify patients that have a macro present. And again, more on this later. So what about some exogenous and endogenous interferences? So one that everyone's pretty familiar with that can affect many assays, not just troponin, is biotin, especially for antibody-based measurements. And here you can see a nice publication where you can see that the different biotin concentrations will affect certain types of assays. And importantly, manufacturers have done a good job to try to mitigate this effect. And here's an example for the Roche assay where previous version and a newer version the newer version is much less susceptible to biotin. Still affects it, but at very high, very, very, very high concentrations. Importantly, what isn't always appreciated is that you could have a couple of interferences or a couple of variables affecting troponin results occurring at the same time. And in doing so, you can actually see the fact is that if with, for example, the newer version of troponin T assay, which is very less susceptible to biotin, if that sample actually had a lot of hemolysis, which would also affect troponin T, causing possibly lower, you can see at a concentration at about 1,500 nanograms per liter, the troponin T would be significantly lower with the presence of hemolysis at that biotin concentration. Whereas in the presence of no hemolysis at all, the troponin T is not affected. So again, something to keep mindful on is that sometimes you could have two things occurring. It's not just one variable that could be affecting assays. The second aspect is endogenous, and I think this is an important topic in the fact that we have a bunch of A things here. We have alkaline phosphatase and perhaps some acute phase reactants, and these are assay specific. So here's a nice example where reagents, antibodies that use alkaline phosphatase, if there are individuals with high alkaline phosphatase, you may start to see discrepant results between sample types. So for example, here is the difference. This top value, these are all normal or very low samples by one assay, but you can see with the assay that's affected by alkaline phosphatase, the absolute difference, and this would be between Beckman and lithium heparin versus EDTA, is about 8 nanograms per liter. Again, but if you were to then use EDTA plasma, it actually yields a lower concentration, very similar, or at least in line with what Abbott would give you. So again, something to be mindful on is that patients may have high endogenous alkaline phosphatase, which may impact perhaps some concentrations, and different sample types may mediate or mitigate that effect. The other aspect that just recently came to the scene is the presence of acute phase reactants that cause some, what we think is perhaps some non-specific binding. I won't go into a lot of details here, but I just want to show you, and more is in this publication here, that a patient with one assay has this nice rise fall with one troponin assay, but basically a stable concentration with another assay. And upon further review, indeed, this patient did not have anything wrong with their heart. In fact, it was non-cardiac related diagnosis at all. But this was pretty surprising, this rise and fall, which would kind of be suggestive of an acute phase response where we see higher values, lower values. And again, this is important because what we can see here, that this presence of a high acute phase reactant could cause perhaps some non-reproducibility, and that's illustrated in the table below, where we see patient EDTA lithium heparin, we see vastly different results between the two and pretty high coefficients of variation. So something that should, again, be something that individuals, if your laboratory is offering assay, that you need to understand what are some exogenous and endogenous interference that could impact troponin assays. So in the last few minutes, when do we do this type of investigation? Obviously during method instrument validation, during investigating QC and other QA practices, and obviously during a clinical request. And again, one of the recommendations, recommendation 6 from a joint document by the IFCC and at that time ACC Academy, said that laboratories should communicate with clinicians on the influence of pre-analytic and analytical problems that confound troponin assays. So during method, instrument, and ongoing validations. So on the left is an example where we will see that there are differences between different lots. So here's a quality control material that we ran on a 100 test pack versus a 500 test pack. And you can see all the different lots that happen. And the circles are the mean and the bars represent the SD. So you can clearly see that definitely with the 100 test pack, there was definitely some lots that had suboptimal performance. And this didn't really have to do with perhaps the lot number, but perhaps some other interference that we were able to identify. And then obviously during method validations, when you actually transition from a contemporary assay to a high sensitivity assay, and here's an example of the correlation between ortho high sensitivity versus ortho contemporary assay, and Abbott high sensitivity versus ortho contemporary assay. Abbott's in green, ortho's in red. And I just want to circle in on where you actually see the discordances. When you actually see that there are a lot of results of yielding positive concentrations or concentrations that are indicative of myocardial injury with one assay and not the other assays, those are the types of samples that you really want to investigate further. And in doing so, what you will see here, and then that's also in the same publication, you can see that the circle dots are all troponin that is basically elevated by, say, one assay and negative or normal with another assay. And all of these samples are from patients that actually have an acute phase response and not related to cardiac injury. So during investigating QC and other QA practices, so this is important, and the fact is that sometimes you will see that you may need to put in something to prevent or mitigate fibrin or microclots to occur. And here's an example where a filter was done after troponin was, after sample was drawn, measured before the filter and then after placing the sample filter. You can see that a lot of these non-specific binding, most likely due to fibrin, was eliminated. You can see that sample type on your right-hand side can improve the reproducibility of certain types of assays. So something to be mindful on if you're finding that there's too much variability, perhaps a tube could have the aspect. Simple things such, and this is in the bottom left, simple things such as repeatability. Everyone does within run when you evaluate an assay, but how often do you do it during the course of investigating a problem? So in this particular case with a contemporary assay, what we saw was the fact is that a simple within run experiment demonstrated that the first sample, the first measurement always yielded a higher result than the other subsequent 9. And this kind of highlighted there was a problem with perhaps something to do with that pack, and that stopped it. And finally, which was kind of brings it all together, here's an example where we looked at 11 patients, had all 3 sample types, serum, EDTA, lithium heparin, and we measured them all in 11, and we said, okay, well, how many of them can actually yield discrepant results, could change management in the ESC01 algorithms? And basically all assays were affected. All assays could yield different results that could lead in this classification, some more than others, but it's just to kind of obviously solidify the point that you don't want to mix up sample types. And during a clinical request, well, fortunately, you can listen to Dr. Hammersten. Little things mean a lot, and he's going to tell us why that case. And then, of course, Dr. Jaffe, how could you not listen to a person who knows everything about troponin, and he knows it with that big smile. And for those who are interested, there's a publication below where we actually go through some of these and issues, some variables in a little bit more detail about storage, sample integrity, and interferences. And so with that, some takeaways for you. There are several analytical and biological variables affect troponin assays. Again, these are the 5 that I like to group it in. Detecting and communicating to clinicians on variables affecting cardiac troponin assays is an important task for laboratory professionals. And finally, special acknowledgement thanks to all the collaborators and staff that have helped the work presented today. And with that, I will stop.
Thank you very much, Pete. That was excellent. Very interesting talk. Thank you. We will have the questions afterwards. So now we will go directly to our second speaker, which is Dr. Ola Hammarsten from the University of Gothenburg. Dr. Hammarsten is a professor. He has been publishing and working with troponins for many years, and he has specialized in producing assays for detecting troponin interference. So thank you very much, Ola, and welcome. We are eager to hear your presentation.
Thank you very much. It's a privilege to be able to present here. And my starting point here is that, sorry, I've been doing investigations for troponin interference for roughly 3 years now on a national basis in Sweden. And the information that I have is based on my own experience. I like this. An expert is a person who has made all the mistakes that can be made in a very narrow field. And basically what I'm going to tell you now is sort of hands-on recommendations that I have sort of evolved during the time doing this. So in general, all the troponin assays that are used in clinical use, they are a sandwich type of assays where 2 antibodies must localize on the same troponin molecule. Usually one of the antibodies is a catch antibody and the other antibody is the signal antibody. There are 2 ways, as it seems, that can result in a false elevation of troponin. The first one is hydrophil antibodies. So in this case, you get a patient antibody that brings these two antibodies together in a troponin-independent manner, and then generating a false elevation. The other is the macrotroponins that Pete mentioned in his presentation. And the way that the macrotroponin works is that in the normal case, we have to assume that there is a constant leakage of troponin into the circulation because we have stable levels, right? So that's the only way you can have something that is stable, that is produced and cleared by the same rate. But if the patient has anti-troponin antibodies, what will happen is that these antibodies will bind to troponin, usually a fragment of troponin, and prevent it from reaching the kidney, and therefore it gets a longer half-life. So in the circulation, troponin has a half-life for roughly 1 hour, whereas an antibody has a half-life of several weeks. So what you do is that you build up a false elevation that does not reflect increased release from the heart. And much of what I'm going to talk about is by a new paper from our group that we're very proud of producing, and which you can look at. And in my referral center, where we have investigated almost 200 cases, the typical findings is that there is a stable level of troponin that doesn't match the clinic. That result in that those are the patients that are referred to my clinic, they are usually young and healthy. So there is no way you can find another troponin elevating condition in these individuals. Another finding could be that you have an elevation that persists long after a cardiac event, such as myocarditis, and you follow up the troponin sometimes, and you see that they don't go down to normal, and that could be due to autoantibodies to usually troponin I, and an increase in troponin I via macrotroponin. Another thing that is also usual when you have macrotroponin is that you get a variation. So if you run several analyses on the same tube several times, you see that the variation is larger than normal. But most of the cases that I have investigated did not have that indicative marker. And most importantly, what you also see that there is a large difference between different troponin methods, especially if you compare a troponin I method to troponin T and vice versa. The methods that are used in troponin investigations are typically that you analyze with another troponin method, preferably troponin T if there is a suspicion that there is a macrotroponin I and so forth. Then you can also use protein GA to remove immunoglobulin. So this protein G or protein A resin binds to IgG and removes all IgG from the sample. And if the troponin is part of an IgG troponin complex, then also troponin will disappear, which is not the case if you have a myocardial infarction and so forth. Other methods that have been used is PEG precipitation dilution and HBT tubes. I personally have tested 2 of those, and I found that sometimes the result is very hard to interpret, because if you say to the clinician, this troponin is falsely elevated, you actually you could do harm. So for that reason, my feeling of using PEG precipitation and sometimes generates results that you can't trust. So that is also true for the other methods, but in general that is the case. Then you have reference methods, the gel filtration or sucrose gradient centrifugation. Both are size-dependent separation. So the troponins that are circulating in blood have a molecular weight around between 20 and 40 kilodaltons, whereas antibodies has a molecular weight of 150 kilodaltons. So what would happen is that you find that the troponin in the patient sample has high molecular weight, and therefore you can infer that this is due to macrotroponin or heterophilic antibodies. So this is the way I do things. At the moment, I didn't start out like this. So I've learned, but maybe not used the most efficient and secure way to exclude or macrotroponin. So when someone refers to me, they send it to lithium heparin gel tubes, centrifuged, and they can be shipped at room temperature also during weekends. And when they arrive, they could store it in the freezer or the fridge, and it's stable for more than 1 week. I mean, it's in the freezer, it's stable for many, many years, as Kavsak very nicely shown. What I then do is to do the protein G column to remove IgG, and in that process, I also do 2.4-fold dilution, so I do a dilution test. Then we analyze troponin T and troponin I and ferritin. Ferritin is used to check for non-specific losses during the column spin column method. And if the troponin is less than 40% after removal of IgG, and there's very low levels of troponin I or T in the sample, then I say that this is a troponin interference. In many cases, though, these results are not conclusive, and then I do the sucrose gradient ultracentrifugation, and that so far has always given me the right answer, and I will discuss this shortly. This is the spin column method. So you start with the centrifuging the plasma to remove any free beam clots and so forth. And then you have your protein G in a column. You can buy it from Biorad. It's stored in 25% ethanol. And then you take away the ethanol and you rinse once. We can speed up this. I mean, you get the... So you get the flow through and then an eluate, and then you can restore the protein G and store it in 25% ethanol. However, it's very, very important to clean the column several times with the pH2 glycine to prevent carryover effects between runs. So the typical result from this is that I'm first using the input. So I do a dilution of the plasma with 250 microliters of plasma, 350 microliters of TBS. And I do a similar thing, and I push that through the column and collect the flow through that comes out there. And this flow through is then devoid of IgG. Then I do a wash step, and after that I elute with glycine buffer. And I also measure an undiluted plasma sample. And a typical result will be that you have a measurable amount of ferritin, in this case a high troponin I and low troponin T. And in the flow through, what you see then is that you get a decrease in the troponin level specifically, not very much for the ferritin and not very much for the troponin T. Then you have the wash, and then you can also see whether or not you get some troponin in the eluate. In this case, there was. And finally, you will also analyze the sample, and in some cases there is a huge difference between the different assays. So you see a 5-fold difference. You can say that this is likely interference on the assay that gives the higher value. When it comes to leading out or giving the answer on your investigations, this is the way I do it. I explain first that your patient has a macrotroponin that is a long-lived immune complex with troponin I and antibody of the IgG type. It leads to stable increases of troponin I without increased leakage from the heart. And then I'm also giving the troponin levels measured from the sample and how much reduction there was after a removal of IgG, and that should be more than 60% reduction. And then you also comment on the second troponin that was not involved in the interference, and then I also give the clinician some advice about how to circumvent this problem in the future. So in this case, I'm just stating that in the future, if it's possible, use troponin T instead if patient comes to the emergency room. So this is a classical case. It's actually a true case. It's a male, 42 years. He had a STEMI 2 years ago. And 6 months ago, he got a stent thrombosis. He got a stent on the first myocardial infarction. And now for a third time, he comes into the emergency room with infection and stable troponin elevations around 100 nanograms per liter. Cardiac MR showed scarring from previous events, but nothing new. No clear sign of myocarditis, and the lab workup were normal. So the results that I get then is that the TNI in the input to the column was 74 nanograms per liter and only 1 nanograms per liter after removal of IgG, and nothing happened with the troponin T measurement. So the interpretation that this is a macrotroponin, and likely it was the previous infarctions that immunized. So if there is discrepancy between these different assays, I mean, let's say that both troponin I and T are increased, and after running through the protein G column, you get a reduction of 50% or something. What we do? Well, in my case, I'm using a reference method, which is basically an ultracentrifugation. And here I'm just showing how you make the gradient. So the different sucrose layers, with different sucrose concentrations, you pipette them on top of each other with a freezing in between. So you're basically getting 4 layers of sucrose ice with different sucrose concentrations. And then you can store these tubes with a lid for many, many months in the freezer. And when you need them, you can take them up and then thaw them, and then just add your sample onto the gradient. And then you run down to the cellar where there's an ultracentrifuge, and the centrifuge for 20 hours. And then you take up the tubes, and then you pipette from the top fractions of 200 microliters, and then these fractions are then analyzed for different things. So here can you see how a molecular weight marker that I also developed together with the assay behaves. So this is myoglobulin, 17 kilodaltons, and let's see here. Yes. And here is IgG, 150 kilodaltons. So you see you can get a decent separation here. So when you do this assay on type 1 myocardial infarction, this is just one patient, but I measured both troponin T and troponin I. You see that comes out around 17 to 40, 50 kilodaltons, like this. So this is for a myocardial infarction patient, and this is for a patient that has macrotroponin. So you see that there is the difference where they come out in the You don't have to do this with 20 fractions. It's actually possible to take one low, one intermediate, and one high molecular weight fraction from each tube and just run the troponin assays. And as a size marker controls, I usually use ferritin, anti-proBNP, and TSH. Ferritin has a very high molecular weight, around 500 kilodaltons. Anti-proBNP has low molecular weight, that is roughly the same as for troponin T. And the TSH has a molecular weight around 40, which comes out roughly around the troponin I, the free form of troponin I. So the result from this clinic that was summarized a year back when we only had 109 investigations, you see that the median age is low and male sex is 68% and so forth. And in 97% of the cases, if the patient had interference as an explanation for the troponin elevation. And to me, that indicates that there is an undersampling. Probably if someone comes in with a stable troponin level of around 50 and had a heart failure and kidney failure, maybe you will not investigate that person regarding possible interference. But that's just a guess from my part. And finally, the pitfalls. You can have macrotroponin that involves both troponin I and troponin T. What will happen then, you have stable levels of both of these, and that's an indication this might not be that is coming from the heart. What happens then is that you get the reduction of both troponin I and troponin T when you remove the immunoglobulins. Then an isolated troponin T elevation is also something that you can see in patients with skeletal muscle disease. Also, chronic myocardial injury tend to have roughly twofold higher troponin T levels compared to troponin I. One problem also can be that there could be, for instance, myocarditis together with the macrotroponin. I just want to show one case here. This is the sucrose gradient on this patient's plasma, and the reason she was referred to me but it was sort of an acute case. She had a myocarditis after a ski race, Vasaloppet in Sweden, and she got chest pain 2 days later, and she was investigated, but so there's just a small part of the heart that showed movement abnormalities, and it did not match the 40,000 nanograms per liter that she had for troponin I with the Abbott assay. And in this case, it turned out that there was actually some free troponin I and a troponin I macrotroponin complex. So that free troponin I would roughly give her 4,000 in troponin I, which according to the clinician were more in line with the other findings on UCG. And lastly, during the first days in a myocardial infarction, there will be a higher level of troponin I compared to troponin T. The plot you see here is that the troponin T is in the black line and the troponin I is in the gray line. And it's from a study where they measured both troponin T from Roche assay and the troponin I from the Abbott assay on patients with STEMI. And you see there's a large difference. So so you also have to make sure that when you do investigation, you only do that on stable patients. And finally, I haven't talked about heterophiles. And we have developed a new assay we think work. What we've done here is that we ordered peptides covering the epitope for one of the antibodies in the troponin assay. So that if you add that peptide to the patient sample, then run it on an Analytical or something, then you get almost no result. The level signal will be lost. Whereas if you have a troponin independent signal, like from heterophile antibody, you will still get the signal. And here is patients that, according to my other methods, had macrotroponin complexes, but it turns out that this patient I likely have heterophile antibodies, since the peptide wasn't able to block that. And this is not published yet, but it will come. And with that, I'm done. Thank you.
Thank you very much, Ola. You can stop sharing your slides now, and I will welcome the next speaker, which is Dr. Alan Jaffe. Dr. Jaffe is Wayne and Catherine Preisel Professor of Cardiovascular Disease. He is a notable expert on cardiac biomarkers, and I would say probably one of the founding fathers of the whole field. He has been publishing in this field for 40 years at least. So we are very honored and glad that you are here with us, Dr. Jaffe. And he will discuss the clinical importance of macrotroponins and how they can be confounding. So welcome, Dr. Jaffe. We are looking forward to your talk.
Thank you, Kristin. I'm not sure my slides are showing up.
No,
right
they
way.
are not.
I can see them. Now I'm getting.
There is a problem with the slides. Could you help us, Esmeralda?
Yes, can you open the slides and then go to full presentation mode?
They're open. It's
Yes.
full presentation
Yes,
mode.
perfect.
Is that okay?
Yes, it's fine. Thank you.
Okay. Well, it would be difficult to talk about after my sophisticated colleagues are talking about all these technical issues about only macrotroponins. But I do want to give the audience some sort of sense of what clinicians think about and what clinicians may need. Because the reality is that clinicians may not get into these weeds, but they want to be sure that the values that they're dealing with are correct. And in point of fact, the best way to undercut the utility of using troponin, and in particular high sensitivity troponin, is by having values that clinicians have difficulty dealing with. I can tell you that although my colleagues didn't cover this in detail, I throw this in just to reinforce some of the stuff that Pete said. It's not just antibodies that are important here. This is our original publication having to do with outliers, values that were different by at least 3 nanograms per liter, and we found them in 3.1% with high sensitivity troponin T. And when we look, this is from an abstract at AACC, the new 6th generation troponin T has even more. Now, this is not unique to troponin T. At AACC, or ADLM, if you wish, there were 2 abstracts about the Beckman assay, one that showed a 1% incidence and one that showed a 12% incidence. So flyers exist. Pete showed you elegantly the difference between plasma and serum, but this becomes the real world often. You don't have the right sample, and so you use it. And the same thing from platform to platform, something that was not talked about. In addition, this is the precision profile of our troponin T assay that was published in 2011 by Amy Sanger when we did our first evaluation. And as you can see, there's a fair amount of imprecision in all assays as one gets down into the lower end. And this was elucidated by Pete Kavsak. And he showed you the slide. I'm going to just show you it in a word slide where he put samples on the table and remeasured them 3 times over 3.5 hours. And we use, and I'm not going to show you this in detail, but most of you probably are aware, most places with high sensitivity use either the 1 hour or the 2 hour algorithm, which uses very small differences to distinguish between patients who rule in, who rule out, and who get to the observe zone. And what Pete showed was that when one did this, that the values that were 18 values that were at the low end, 1/3 of patients changed classification. The pushback has been, well, maybe there's not anything clinically that is associated with this because everything looks so good clinically. And I would point out that there are a couple of signals that one should be sensitive to. These are data that come from the RAPID trial from Australia. It's a funny trial, and it's more complicated than it may first appear because they mask some of the values. But they basically compared the 0-1 hour ESC algorithm and found that 13% of their patients represented. Wasn't clear if that was due to the single sample part of this or due to the delta, but potentially this may be a signal that these sorts of analytic problems that we're well aware of can be problematic. Long term, something similar was observed with an increased hazard ratio even for mortality. The consequence of that is that the Mayo Clinic, when we moved, used a 2 hour algorithm to avoid as much as possible some of these analytic confounds. In addition, we repeat all initial increases in high sensitivity troponin T to make sure that the changes that we see are not flyers. This turns out to be relatively more important than you might think, in particularly because our hospitals are full. And we have on a couple of occasions failed to do this and admitted patients who eventually turned out to have analytic reasons for an elevated troponin T that wasn't repaired, redone, and consequently led to increasing difficulties in terms of just our ability to take care of patients. So, what clinical circumstances should we consider? Well, I'm going to give you several examples where this can occur and be very important. The first is if you do have troponin values that are discordant with the clinical circumstance. We see this a lot. Some of this has to do with the fact that clinicians are not as sensitive to the fact that troponin can be chronically elevated, as Ola pointed out, and you can have chronic myocardial injury. But in patients who are presenting with possible ACS, who seem to be low risk and have elevated troponins, or seem to be high risk and have normal troponins, there clearly are discrepancies. And what we need to help clinicians do is feel comfortable contacting the lab when these occur to make sure this isn't an analytic problem. Now I'm going to show you a couple of cases to give you a sense of the complexity with which clinicians need help. This was a woman who I saw actually had a history of hypertension and chest pain, was having more of late, had a day's worth of tightness before coming to the ED. And because she recently had a stress test that was unremarkable, They did a CT looking for pulmonary embolism. It was normal. So they admitted her to the ischemic heart disease service. That happened to be me at the time. Here's her electrocardiogram. Fairly unremarkable. Her troponins are below. And actually, I heard about her and it was 10 and 10. And I worried that this might be what we call a late presenter, which I won't talk about in more detail. But one needs to be careful in patients who come in late after the onset of their clinical syndrome, because they could be on the downslope of the time concentration curve, which is much slower than the upstroke. And the Sweetheart study has suggested that as many as 26% of patients with MI can fit in this category. So what I teach to my residents and fellows is that if you have that potential circumstance, a third value is necessary. Actually, the third value became elevated. But when I went to see her, it became clear that they had sent her to the echo lab, and she had, if it'll play, a abnormality. You don't need to be well, it didn't play. You don't have to be an expert, but there was a regional wall motion abnormality in her septum where the arrow is. So this lady, for all the world, looks like she's got something. So I sent her to the cath lab. She had a normal angiogram. They did an MRI, and she had a perfusion defect in her septum, same place. This is called myocardial infarction with non-obstructive coronary arteries, MINOCA. And it is one of the areas where this need to know whether troponins are truly increased or not becomes critical. If one looks at these patients, often, and I'm not here to advocate this for everybody, but for selected patients, they often have MRIs. And if you look, myocarditis is the most common mimicker. Small infarcts are present in about 25% of people, and a variety of other cardiovascular diagnoses. So most of the time when the troponin is elevated, it comports, even in the complicated patients, to something being amiss. And this is a complicated circumstance for clinicians, because actually, if you do sophisticated imaging, some of these patients have plaque rupture, as shown here. The truth is that their prognosis is much worse than people who have normal heart arteries. It's not as bad as those who have really obstructed heart arteries. So this is one flavor. But here's another case that I was called by one of my colleagues just last week. It's a 55-year-old woman who had 4 MINOCA events in the past 4 years. That is to say, she came in, she had chest symptoms that someone thought were suggestive of myocardial infarction, myocardial injury. And she had troponins that were done elsewhere that were substantially elevated, 170, 281, and 356. So she came here for a second opinion. A troponin T here, even though it was between episodes, and that's important, was normal. But she had a normal coronary angiogram with no obstructive disease, although there was a question as to whether or not she could have vasospasm. And when we get into these cases, we, meaning clinicians, have a tendency to look for every little tiny thing. Had a bunch of echoes, a bunch of MRIs that showed no abnormalities. So my colleague said to me, what should we do? And my suggestion was that the next time this lady presents to an outside hospital, which is where she usually goes because she doesn't live close to where I practice, we should get her troponin I measured And in anticipation of that, we should send them something really very simple, which is to say HBT tubes or scantibodies. They're not perfect, but in point of fact, when she came in the next time, her troponin was still in the 150 range. They sent us the sample. It was normal by troponin T. And after the addition of HBT reagents, her troponin I normalized. This may not be a macro, but in point of fact, I'm not so sure, and would leave this to my more technically oriented laboratory colleagues, whether or not some of the antibodies we call heterophiles are part of the macro complex and vice versa. Nonetheless, this appeared to be a false positive elevation. And we were able to say, in part because everything fit together, that this woman should no longer be evaluated with that particular assay. Because usually, as Ola showed you earlier, although not always, a second assay is not equally affected by whatever interference there is, whether it's a macro or something else. Now, where have we seen interferences that cause confusion? I just showed you an example of possible ACS and possible MINOCA. Both of them occur because common things happen commonly. If you start thinking about the number of patients in the United States that come to the emergency room with chest pain, it's 10 million a year. So even if this is a small percentage, it's a large number. But there are also a variety of other circumstances. Possible myocarditis is the most common, and that's because we see all these patients with atypical chest discomfort, and if they have an elevated troponin and we can't explain it and we know their coronary arteries are all right, they become labeled as having myocarditis, including, by the way, if they have COVID often, including if they are post-COVID vaccination. And recently, these examples were published by the Edinburgh group in clinical chemistry. There are 3 patients, two of whom actually came from Ola's group in Gothenburg, who came in and appeared to have either COVID or post-COVID vaccination elevations in troponin with atypical chest discomfort. I'm not going to go over each one of these cases, but there are complexities. But they all had normal physical examination and imaging studies of a variety of sorts. And there were some complexities, but all had a confounding interference, mostly with an evidence of a macrotroponin. One begins to consider this whole issue. One should remember that what COVID does is evoke a very, very robust immunoglobulin response, and that's what we try and mimic with vaccines. So it could well turn out that this could become a more common example, and we need to be circumspect in these patients before we label them all as having a clinical syndrome that perhaps in the long run is not indeed what they have. Now, some people have looked at how often this is, and they found that at least some findings of antibody-mediated complications can occur in up to 50% of patients with assays. They cause modest increases, and they vary across all of the assays, but all of the assays manifest some. Interestingly and importantly, in the past, it's been understood that antibodies to troponin can, in the setting of myocardial infarction, be associated with an adverse prognosis. And in point of fact, in addition to identifying these patients so they are not treated inappropriately, there may well be in the long run an importance to making sure that if indeed they have a macrotroponin, they can be identified. You can also see that if they have a false positive, they're at much less risk than if they have a true positive troponin. Now, does an alternative assay solve everything? Well, Ola already showed you it doesn't. But I want to just remind many of you in the audience that troponin T tends to detect many, many more patients with myocardial injury that is not ischemic. As shown here, it's associated with an adverse prognosis. So it's not benign to have an elevated troponin T versus I when you don't have ischemic heart disease, but it's not quite the same. So we need to be very careful. So what ought we to do? The first is to rely on clinical correlation always. If the values don't fit, we need to evaluate it. Deltas are terribly important when there are high values. All of these interferences, and there are obviously exceptions to every rule, depending upon the degree of clinical perturbation that exists, by and large stay fairly stable. So the deltas are important to emphasize to clinicians. It is also worthwhile for laboratories to have another platform, because often, if indeed the values are discordant and one value comports better to the clinical diagnosis, that's the value that ought to be relied on. And finally, if one is really stuck, there are sophisticated laboratories like those that Pete Kavsak and Ola Hammarsten run who can help you explain the differences. And with that, I will stop.
Thank you very much, Alan. That was excellent. Thank you. We have a lot of questions coming in from the audience, and we have a few minutes to discuss them. And I think I will start with one question, which I think is maybe towards you, Ola, first. But there is one person asking, how realistic is it to expect that most labs are able to address these interference in real time to assist patient care and clinical concerns? So you could maybe start, and the other speakers here could add on.
Yeah, I understand, but most labs do PEG presentations for macroprolactin. And although PEG presentation gives funny results on troponins sometimes. If you get a clear-cut answer, you have 400 nanograms per liter, and then after PEG precipitation, you have 4 nanograms per liter. I mean, that's better than nothing. But it could also be that maybe we need to set up at least a simple protein G spin column, so that, because the prevalence of these false elevations seem to be troublesome.
Yeah, I'll just chime in on the part that mentioned real time. Oh, that's difficult. I don't know of a way to identify a troponin elevation in real time that's not due to like actual myocardial injury or other clinical issues that can cause a troponin elevation. That is really challenging. We do provide a service, but it's nothing, it does take time. And it's only usually after clinicians have done their due diligence and realize that maybe something's not quite sitting quite right with the troponin assay, and then they contact the lab, and then we start our own investigations. Real time, I don't know, if we could think about something like that, that's almost like holy grail to say, like, as someone's being evaluated, because I don't know, maybe Alan has a wiser.
I do think there's some things you can do. They're not perfect, larger centers can have alternative assays available. And as I noted to you, I think we would probably most agree that if something's clinically pretty clear cut in one direction or the other, that if there's discrepancy between those two assays, that would be helpful. Not perfect. Some of the other less than perfect techniques that Ola suggested, though, are not unreasonable either. So, for example, in the example I showed you, we didn't have the patient here. We sent scantibody tubes. They're not perfect, but if they unmask something that clinically gives one an understanding of what's going on, that's helpful. If one does PEG precipitation, which is not hard either, it's a dirty technique. I understand. The same thing with dilution studies. They're not perfect. But if they all tell you that those are simple things, and they all tell you that this value is too high, and it could be too low, although people usually don't focus on those that are too low, then that may give you a short-term clinical answer. So I would argue that some of these less perfect techniques sometimes can be clinically valuable for a lab that is smaller and needs an answer.
Yeah. Is it possible for me to add something? Yeah. So I've been going through my interference studies on these few hundred patients, and the dilution seldom gives you a clear-cut answer. But since we have both troponin T and troponin I platforms on this hospital, in the beginning I got a lot of referrals from the local physicians, but then they saw the trick I was doing. I run both troponin I and troponin T, and I after a while said, well, we're going to open up the possibility to order troponin T, and now they don't send any referrals to me anymore. So, I mean, it could be that opening up one additional platform for the clinicians, maybe in 9 or 10 cases, the clinician can take care of it by themselves, after some education from the lab staff, of course.
I could also add that because we don't have any sophisticated measures for this in my lab, but our experience is that we come very far if we can analyze on an additional platform. And this will actually be much easier when the point of care assays are more available, because it's cheaper to have an in-house point of care compared to sending to another hospital. So that could actually make this easier. I think we should move on.
Kristin, I might just add that there has been chatter, I won't say that it is science, that point of care assays tend to have fewer of these. And that may have to do with the fact that in a lot of these internal devices, there's a separation of plasma and the red cells early on that may trap some of these macros. So theoretically, it could turn out, and we need to have people like Ola and Pete do these studies, that a point of care assay may have some value in unmasking, in particularly the macros.
We then move on to the next question, which is actually related to point of care assays. And there is one of the viewers who is asking, at what point do these interference apply for point of care troponins? Are there studies performed that compare point of care versus core lab? And I think this is related to all interference, not only macros, but all interference that we see.
I'm just going to say, I'll just chime in. There's a really great publication, and I'm going to plug it, by the IFCC CB committee. Paul Collinson is lead author, that talks about how one ought to go about evaluating point of care assays. And realistically, they should be evaluated exactly the same as a core lab. So before enthusiasm gets up too high on point of care testing, there has to be a lot of work done on point of care to evaluate it in a lot of different settings, a lot of interferences. You can even just take first principles, like look at just the blood gas measurements. Very recently, and up until very recently, people don't even know if hemolysis can be affected. And a lot of times you can't even detect that on the blood gas. So these are really important things that will have to be tackled in a more systematic manner before really thinking that, point of care is holy grail. I don't see it necessarily being, it could be a tool, but I do think there's a lot of work to be done.
And they're not just analytic problems. There are some clinical problems as well. For example, there is a small difference between capillary and plasma and venous blood. It's modest in normals. What is it like in patients in shock or in congestive heart failure? We have no clue. And the sample type, when one gets a capillary sample, is not very good. So there are all kinds of vagaries having to do with sample type, to say nothing of the instruments, their maintenance, and all of these other confounding problems, so that we're making progress. It's a good progress. The paper that Pete referenced is a good one for people to get background in, but all the I's are not dotted and all the T's have not yet been crossed.
Okay, thank you. There is another question here, which is more related to autoantibodies and macros again. There is some participant asking, in which condition do we suspect autoantibodies against troponins? Is there any particular conditions? That there are several questions related to this. There is also somebody asking about, can this interference lead to negative results, like false negative results? So I don't know.
Well, the answer to the first question is that in those that I have investigated, there is no clear-cut accumulation of patients with autoimmune disease or so forth. They are there, but in most of the cases, no, we can't sort of say why this person have an anti-troponin I antibody and the other one hasn't. But there are studies, but using contemporary assays that particularly heterophile antibodies is in the frequency of those that interfere with troponin assays are more frequent among patients with rheumatic disease, but that is from China. So it's not clear how that will be applicable here. So we have very little information about this.
There are data from the group in Heidelberg suggesting that there are about 6% of patients post-myocardial infarction will develop anti-troponin antibodies, and they are associated with abnormalities in remodeling. Maybe that means there's persistent, ongoing release of troponin, or perhaps it means that some of the fragments that may be elaborated may have biologic significance. That's yet to be determined. But one might suspect that in some of these patients should have some sort of antecedent release of troponin to end up getting into the circulation to cause an antibody response.
Yeah, and the only thing I can add is that, and this is not necessarily a bad word, but I think it's a confounder. There's always a selection bias. So in the cases that go to Ola or to myself, it's usually cardiologists who've been working up patients extensively, and they say, nah, something's not right here. Let's contact the lab. And then in other cases, the fact of the matter is like who presents. And sometimes anecdotally, it seems it's usually the younger, perhaps female population, which we all recognize are missed sometimes for myocardial infarction. But I think that's been a big problem in the field, is that there hasn't been a wide, large, systematic study to assess this aspect. And more importantly, it's even the temporal relationship. Do we know that if you have a macro one time with one assay, is that the case over a few years? Well, for one patient, we saw it was, but that doesn't necessarily mean that'll be always the case for all the patients. So I do think there's probably a greater need to have, what is a patient? Right now, I think it has to be clinically determined. And I think the IFCC document puts that right up to the front into the nice algorithm that's put out there, is this like, clinically there's a request to do this, and that's how laboratory gets involved. But until we do a large study in this aspect, some of these questions will remain unanswered for sure.
Yes, there is another question as well regarding this. It's you have partly responded already, but there is somebody asking, is it possible that this patient, one of the patients that you showed, Ola, could have a genuine pathological release of troponins on the background on for instance, autoantibodies? And that is, I would like to add to that question, could it be dangerous? Or
well, what I've found is that most often the other troponin is low or sufficiently low to say that we trust that value because it sort of fits with the clinical information as well. But I agree with you. I mean, the amount of troponin we have in the blood is a result of release rate and clearance rate. So, I mean, it's I think the only take-home message here is that you cannot use the assay for which you have identified an antibody-mediated interference, because there's no, you have very little data on that type of patient. And it sort of pops the question in a few cases where there's interference for both troponin I and T. My last sentence in my replies, I just say that I don't know how you should handle this patient if they come again. But I mean, maybe Alan has some idea.
I wish I had 100%. I'm not sure that, first of all, let's say that as we're getting to high sensitivity, we're beginning to get to the point where alternative mechanisms by which troponin can be released and cleared are being at least studyable. And it may well be that some of these alternative mechanisms, whether or not they have to do with apoptosis, whether or not they have to do with blebs or exosomes, etc., become important in figuring this out. But we don't know that for now. That said, one of the educational points, and Ola is totally correct, that needs to come across is that clinical judgment, assuming one uses it appropriately and is knowledgeable about troponin, is what has to be what eventually makes the diagnosis in patients. Troponin, as good as it is, and I love the marker, in and of itself alone is not adequate.
okay, we have some more questions here, and I don't know, maybe we have focused too much about macrotroponins related to troponin E, because there is someone here asking, maybe the test of choice for myocardial infarction should be troponin I rather than troponin T. There are also some questions about, but well, this is a very tough question. So, Pete, you are laughing. What do you say? Troponin
No.
T or troponin I?
No, I think you can use troponin I and troponin T equivocally, obviously, and I think you can use any troponin I assay as well. I just think it's really important that laboratory professionals, if you do identify an interference, you communicate it to the clinicians and you come up with a plan to use it appropriately. So assays can be used. So, you know, I think it's just really important to do the due diligence, work collaboratively, but I don't think there's, you know, I don't think T over I. It's like the Cola Wars, Pepsi over Coke or whatever. I'm not going to weigh in more. But I'll stop there.
I'm on the Pepsi side, but I agree with you wholeheartedly.
Yeah, I have one comment. I mean, I get that question a lot because we changed from T to I a few years back. And I think the take home is that the median value of troponin T among healthy is like 10 nanograms per liter, and the URL is 14, very close. Whereas the median level of troponin I in most assays is 2 nanograms per liter, and the cutoff is 10-fold higher. So therefore, probably what happens with troponin I is that you get less of those with myocardial injury type of troponin. But then, and I think we all agree that the data indicates that interference via antibodies is much less common among the troponin for the troponin T assay compared to some of the troponin I assays. So I mean, if you have a good clinical chemist in the hospital, maybe that if you have that ability to test for,
Okay, thank you. Time's up. So I just want to thank all the attendees for watching the webinar. I want to thank Professor Kavsak, Hammarsten, and Professor Jaffe for the interesting presentations and the very good discussion. And I, of course, also want to thank Dr. Hamilton for coordinating this webinar from the IFCC and offering this tool for electronic learning. Please remember that there are some questions you need to answer after the webinar for you to have your certificate of attendance. And also, we were not able to go into all questions that were asked by the attendees, but we will come back to these and respond by email. Also, I would like to inform you that the IFCC is making courses on cardiovascular disease available to the participants, and you can find the links among the resources in the auditorium page. At last, the content of this webinar will be available in short, and you will be informed via email, and you can also find it on the IFCC website. So there will also be many more IFCC webinars. Please look after them when they are announced by the IFCC on website, on the social media, and also by email. So thank you all for attending, and goodbye.